This program is presented by University of California Television. Like what you learn? Visit our website or follow us on Facebook and Twitter to keep up with the latest UCTV programs.
Thank you, Dr. Higashida, and thanks you, all of you, for spending your evening today. Stroke is something that we are both incredibly passionate about in terms of what we can offer, and it's an exciting time in terms of what treatments are coming and what we have in our armamentarium now. But I think some of the basic things are still awareness and education, and so hopefully we can accomplish a little bit of that today. I'm a neurologist, so I actually don't do the fancy imaging and things like that, but we're often the first line of doctors you see if you think you might be having a stroke. So we're a part of a big team of doctors that takes care of stroke patients. So I think we have to start with some basics. So this is the medical definition of what is a stroke. And a stroke is really a sudden change in a person's neurological condition because of a vascular problem, a blood vessel related problem. And when we define a stroke clinically, it's because someone has a deficit that lasts longer than 24 hours, and that's the official definition. You may have also heard the term TIA or mini stroke. That's also a similar entity, but it's a self-limited one where patients recover and they almost have a stroke but not complete in thoroughness. And so it's defined by something that goes away within 24 hours, but in reality these symptoms are transient and last about 15 to 20 minutes. So when we talk about this disease, it's really this sudden change in someone's neurological condition. It's been described historically, even in old kind of tomes from the times of our when we first started historical records, and it was really this term that someone is struck down in their normal everyday life. And I think that that's really meaningful even today. So why is this such an important thing? Globally, we just came off of World Stroke Day last week, and we realize this is a global epidemic. Every 2 seconds, someone in the world dies of a stroke. We're much better than that in the United States, but not much better. Every 6 seconds, someone dies of a stroke. And stroke worldwide is a huge problem, 6.2 million lives a year. And so it's a big global problem that we face. In the United States, we think of it in rank order of diseases that we hear about. And if you think about it, most people don't think about stroke as a deadly disease. They think of heart attack, they think of cancer. So we have made progress. We're actually number 5 on the list now versus number 3. So we're making people better. But that's not good enough. We have to really think about this as a disease that is a vascular disease of the whole body. And unlike heart attacks, which people actually know more about and come to seek medical attention for, people aren't seeking attention for what might be a stroke symptom. And there's maybe many reasons for that. We can see that this affects many people in the United States. As you can see from the color bars here, the highest rates are in the blue and the green. This is what we identify as what we call our stroke belt of our country. Those southern states, from Texas all the way out to Florida. We're a little better on the coast. We're in the purple, not quite as good as Arizona. But I think this is a problem that really is regional as well as global too. And it affects all ages, all genders. We don't think of stroke as a young person's disease, but a small fraction of patients are in their 20s and 30s. The majority of them are older, in their 80s, but it does affect men and women. And I think it's something to think about. This is not a disease that spares anyone. And we also think about it in terms of gender and race and ethnicity. As you get older, obviously the disease continues to get more prevalent, but it affects men and women, both black and white. And really the numbers get staggering when you talk about mortality. Even though we know that Caucasians are more affected by numbers, especially older men, The ones who die from this disease are African American and Hispanic. So we have a disproportionate number of people dying in a health disparities way too. So this is a public health issue that really touches on a lot of the problems that face our health system today. And I put this slide in mainly to sort of say that this is not a one-time disease. This is a chronic disease. This is what happens when you've had a stroke and you become someone at risk for stroke over a decade of your life, if not more. And it also means that these are the risk factors that put you at higher risk over your lifetime. So we'll delve into these a little more, but as you can see in this bottom bar here, this top line is blood pressure. As your blood pressure increases, your stroke rate increases. As you add on risk factors like diabetes, smoking, heart disease, your risks go from very low to very high. And these are things we might be able to do something about. So we'll go down to the basics here. What are the symptoms of a stroke? Why is it so hard for people to sort of recognize these things? So unlike heart attack, which is typically the chest pain, the elephant standing on your chest, stroke is a multifaceted disease. It's not just one thing. So we try to really teach people a variety of basic symptoms. And even then, it fools some of our doctors and emergency room physicians and primary care physicians. It's not that easy. But I think the things you want to take home, it's the sudden onset of weakness, the sudden onset of numbness that affects your arm, your face, your leg, and it typically obeys one side of the body. That's the most common kind of presentation. When you can't speak, or you've lost the ability to understand someone speaking to you, that could be a sign of a stroke. If you lose vision, it can be just your peripheral vision. It can be one eye vision. So it's not even one type of visual loss that I can teach you. You can have dizziness. Dizziness is really common, but sometimes when dizziness comes on very abruptly, causing imbalance and causing someone to lose function in their coordination, that could be a sign of a stroke too. And because stroke is a combination of different symptoms, it can be associated with the worst headache of your life as well. So given that conglomeration of symptoms, no wonder it's so hard for a patient, for a family member, for a doctor to sort out what is happening right in front of them. And one of the biggest challenges is often the person who knows they're having a stroke is incapacitated by the stroke symptoms. They can't call for help. They're not able to activate 911. So we really rely on our community, our family, our kids, our friends to check up on us and make sure that we're not having a stroke too. So it's not just everyone knowing about their own health, it's also passing the message along to your immediate community. So this is something we are using as a stroke awareness project by the American Heart Association and the Stroke Association. If you only remember a few things, and we'll circle back to this at the end of the talk, it's fast. You gotta think fast. The face is drooping, the arm is weak, the speech is challenged, you gotta call 911. It's better to have a false alarm because as you'll hear about the treatments, they're very time sensitive. So we'd rather have people having a false alarm of a stroke and seeking treatment than maybe going to bed and hoping it'll go away by morning. And I think these are the kinds of things that we're trying to promote now in terms of the awareness campaigns. And I think the goal is to really focus on getting more and more people aware of this. So this is sort of part of the challenge. A stroke or a TIA can affect the front of the brain, the anterior part, the posterior part, or the back of the brain. So depending on what part of the brain, you can get a variety of symptoms. I'll define some of these for you because these are medical terms. But if you hit the front of the brain that controls language, you get what we call aphasia. That's typically a left-sided problem of the brain. If you get the right side of the brain, instead of having a speech problem, you may have what we call neglect or inattention and essentially become unaware that there's something wrong with your left side or your right side. So I think these are the challenges of symptoms. If you have had one of these types of events, how is one supposed to call 911? You either can't speak and talk to the phone operator, or you don't realize you're having a stroke and you don't bother calling for help. So these are some of the challenges with stroke patients. If you have a stroke in the back of the head, you might have symptoms on both sides of your body. You might have what we call cranial nerves, which are the nerves that come from the back of the brain to the face. That causes double vision, difficulty speaking, difficulty swallowing. These are what we call cranial nerve deficits. And one of the symptoms is a common one for benign reasons, vertigo. And so, if you just have vertigo by itself, it may not be a big deal. But if you have vertigo with double vision and vertigo with slurred speech, you might as well check in and make sure you're not having a stroke in the back of the head. And because these symptoms can come from a variety of different parts of the brain, it's more challenging diagnostically for your clinicians and for your own family to know. It's not a one symptom, one size fits all, because our brain is a complex organ, and these different parts of the brain work together. So when we have damage to these parts of the brain, it's not one symptom anymore. It's a bunch of different things. To make it even more challenging, it's confusing the terminology. When we say stroke, we mean a vascular problem of the brain. And that could mean, on one side, the bleeding kind of strokes, like a hemorrhage, or it can mean the ischemic side of the things, the blue side, which is a blood clot problem. So you can have either one of these happening to cause those same symptoms. And obviously, it's really important to sort out which one, because they have different treatments and they have different risks for people. When we really talk about the disease of stroke, these are the numbers. The majority is the blood clot type, or what we call ischemic. It's when there's a blood clot either in a vessel in the brain, or it came from some other vessel like the carotid artery or the heart. Hemorrhages are less frequent, but often quite devastating too. And this can be from things like a ruptured aneurysm. It can be from a blood vessel that breaks open. And this is also a stroke, but we call it a hemorrhagic stroke. We're going to focus most of our attention today on the ischemic stroke, the most common entity, the one we have the most treatment algorithms for. But just so everyone in the room knows, the stroke comes not only in different symptom complexes, it comes in different flavors. And so, you're already more sophisticated now than half of our medical school audience who's still learning these things too. So I think it's just important to speak the same language and make sure we have different kinds of strokes that affect patients in different ways and different kinds of treatments depending on which category you fall in. So this is the pathophysiology, and I'll kind of walk through why it's such a big deal. So this is a little schematic of a blood vessel in the brain. So the ischemic stroke, the blood clot type, means that there is something blocking blood flow to a critical part of the brain, and that causes the symptoms of a stroke on the other side. When that blood clot blocks blood flow, our brain is a primary needer of nutrition like glucose and oxygen. It doesn't have a lot of reserve. So once you cut off blood supply, neurons start to die very quickly. And so this is that idea of ischemia, lack of oxygen and nutrients to the brain. It's very, very time sensitive. Right away, those neurons feel this lack of energy and start to have changes. They have energy failure. The electrolytes go out of whack, and the cells start to become toxic, and then they die, a process that we call apoptosis. And so these are the things that, along this ischemic cascade of the brain tissue, we're doing everything to fight against that. So this is the notion that time is brain. Every little second counts because those poor neurons are starving for energy. So we talked about this ischemic stroke. A lot of it depends on what size blood vessel we're talking about. The thrombotic or small vessel type often will have a minor symptom and will often do very well over time. If a larger blood clot comes, let's say, from the heart, then you might have a larger territory stroke with a much bigger risk of a territory at risk. And then sometimes the blood pressure just drops. Someone has a heart attack. They don't have enough blood flow to the brain in general. That can also cause the brain to lose energy and things like that. So I think when we talk about loss of blood supply, that whole term is called ischemia. And depending on the size of the blood clot, the location, you get different kinds of strokes. We kind of break this down a little bit one by one. So this is that thrombotic stroke. These are those little tiny blood vessels that come off the main blood vessels of the brain. So they're smaller, meaning that they are more prone to vascular injury. So when you have a lot of high blood pressure, a lot of cholesterol, a lot of diabetes, these little guys bear the brunt of it. They get plugged up very quickly, and they're tiny. So that you can have a small blood clot form right in those damaged vessels. And these are the ones that get worse with age, unfortunately, and more prevalent in men versus women. And so these are those small blood vessels that cause strokes. When the blood clots come from other parts of the body, we call that embolic. So typically, because we share a lot of the same risk factors with heart disease, often these are blood problems that come from the heart itself. So if you have a leaky valve, or you've had a heart attack and that muscle in the heart is weaker, you can form a blood clot right in the heart. And our body's natural mechanisms will try to dissolve it, but sometimes the clot is too big and it will squeeze that blood clot up into the brain. That's what we call an embolic stroke. You can imagine that's a much larger blood clot. Atrial fibrillation, very, very common cause of stroke. Because that heart is shivering, and when it doesn't beat in a nice regular pattern, blood clots can form in this area of the heart, in that chamber. And when the blood pressure and the heart squeezes again, that blood clot can go up to the brain. So atrial fibrillation is another cause of embolic stroke. As we move higher up, the aorta itself. If there is disease of the aorta, a plaque in the aorta, that can be a site where clot can form and flick off and go to the brain. As we move higher up, the big pipes in the neck, the carotid arteries, another area where you can have narrowing or blockage there, and if it becomes critical, can either cause low flow to the brain, or a piece of that plaque might flick off and go to the brain too. So these are sources of emboli that really can increase the risk of stroke. So a healthy heart goes a long way to a healthy brain. So we really can't disconnect these organs. They're really essentially suffering the same risk factors and impact each other in a big way. So what are these risk factors? We kind of bucket them into what we can modify and what we can't, sort of what you're born with. So the non-modifiable ones, unfortunately, we haven't solved the issue of aging. We're all gonna get older. And that's something we try to age in a healthy way. But as you get older, your stroke risk goes up. We saw that in those early slides. We know there's a differential. Men are more prone to strokes than women. But it's as women live longer than men, we actually catch up. So in the early years, men are getting strokes earlier, but women kind of catch up towards the later years of life. We saw that race ethnicity difference. African Americans, Hispanics, a different complement of risk factors. We're knowing now that blood pressure problems, cholesterol problems, diabetes, these might actually be more prevalent in certain ethnicities. If you have a family history, this may be genetic. Even though you're doing everything you can, you kind of inherited some bad genes, and you got to work against that sometimes. And then there are some specific blood disorders that make you more prone to clotting, and these are genetic as well. So what can we do? There's a whole host of things on the other side of the screen that we can do something about. By far, high blood pressure increases your risk of stroke by 6-fold. That's a big number. And it's not just, yes, no, I have high blood pressure. How much high blood pressure do I have? And so it's not good enough to just be a little high. It's really, you're shooting for the lowest number that you can handle without passing out, right? You don't want so low a blood pressure you're fainting, but you're not going to be out of the woods if your blood pressure is 160. In fact, every kind of degree of blood pressure that increases, both the top number and the bottom number of blood pressure, your stroke risk goes up. So it even matters quantitatively how good your blood pressure is, an average over time. We know that sugar problems are really a big deal in our country, that our diets aren't great, and we have a lot of processed food and sugars, and so diabetes is a real big problem for stroke risk. Similarly, tobacco, we're actually making more strides in California and compared to other states. I mean, it's hard to find places where you can smoke in California, so we don't even have a lot of secondary smoke, but unfortunately, there's a lot of tobacco risks that exists. We talked about heart disease already. Carotid disease, another area. Cholesterol, hyperlipidemia, your cholesterol numbers matter. If you drink too much alcohol, there is a fine line between the good protective effects of a red wine. We have lots of studies on the Mediterranean diet. But once you start to overuse alcohol, you actually make these risk factors worse. And then I think the one that we all know is that a little bit of exercise goes a long way. So if you don't move around very much, you're likely to have more of these risk factors too. So they kind of all play off each other. All right, I know you weren't prepared for this. We're going to take a little quiz. This is your stroke risk quiz. It's really simple, and you don't have to share your answers with anyone. But it really talks about, do you fall in this higher risk category, the red column? Are you mostly in the blue? And if you're mostly in the red, you might want to think about strategizing ways to push yourself into the blue. And so let's kind of go through this a little bit. Is your blood pressure greater than 120/80? And it may take some medicines to do that, but that's a low number. That's actually not the number your doctor tells you or worries about. Most of us are telling you, let's get under 140, let's get under 160. Ideally, your stroke risk goes to the blue when you get around 120 over 80. It's better if you're not 200 over 100. It's better if you're 160 over 70. It's better if you're 140s over 20, 130, or 120. But I think if you can really think about it as a slope, and you want to kind of be on that lower end of that curve, not at the upper end. Do you have atrial fibrillation? That's that irregular heartbeat. Not all atrial fibrillation means you have to take the most potent medicines, but if you have it, you want to make sure your heart is in good health. Is your fasting sugar greater than 100? That's a screening test for diabetes problems. You may not know these things, but maybe next time you see your doctor, you might want to ask. Do you eat a lot of high saturated fats, sweetened beverages, meaning soda, lots of extra salt, lots of extra calories? Those things you might want to think about. Is your total cholesterol greater than 180? We know the number that we advise is less than 200, but what you're hearing is a theme here. 200 is like a threshold number. If you can actually get below that and your bad cholesterol to good cholesterol ratios are favorable, these are actually really beneficial to you. Do you actually exercise? Do you have a family history of stroke? Obviously something you can't change if you have that. Do you smoke? This is from the American Heart Association website, full of wonderful information. This is proprietary, so I don't think they put it in your packet, but if you're interested, they have such an amazing portal for patients and people who care about this, tons of information there. And so this is just something to kind of take your own mental quiz now and see where you fall. Because it's surprising. You might actually see yourself finding more points in the high risk category than you thought. And these are things that we can maybe do something about. I don't know if we're ready to share who's in the high risk or low risk category. Maybe we don't know each other well enough yet. But keep these in mind because this matters to your health and is something you can actually work on. And every little bit counts, absolutely. Okay, so we talked about some of these strategies. So, if you get your blood pressure under control, your cholesterol, your diabetes, you're screened for carotid disease. If you do have these risk factors, you probably should get an ultrasound. Because if you have a critical blockage and you haven't had a stroke yet, guess what's a really good intervention? Opening up that blockage. And you don't open up all of them, but if there's a high risk of narrowing, you want to know about that before anything happens, and the risk of these surgeries are pretty low. And exercise, we all, myself included, could exercise a little bit more. And sometimes it means 2 to 3 times a day, 30 to 40 minutes. Some people do that already, but I think you want to make that a routine, not just a sometimes thing. And we're all busy. We all have things that get in the way of our good habits. So and the holidays are coming up. So I think we want to really build in more exercise as we eat kind of the better food over the holidays. It's a nice balancing act there. Some of the medicines we use specifically lower stroke risk. And ones that are common are what we call antiplatelets, simple as a baby aspirin a day. Sometimes that's all it takes to really reduce stroke risk in someone with risk factors. It's good for heart attacks, it's good for strokes. Sometimes patients need a little more than just a baby aspirin. Some of these fancier drugs like clopidogrel or Plavix, you may have heard of that one. That one's always on the commercials. A little stronger version than an aspirin. There's a combination drug where it's sort of aspirin plus another agent. This one's sometimes called Agranox. So there are combination medicines that people can use to thin the blood a little bit, works on the platelets and keeps them from sticking together. Works really great for those little thrombotic strokes. So imagine that tiny little blood vessel that's hanging on. That little bit of aspirin goes a long way to keep that vessel healthy and open. If you do have atrial fibrillation or a bad heart valve or a heart that doesn't pump so well, sometimes the cardiologist will recommend a stronger blood thinner. And in the past, that meant warfarin. And that's the one that everyone knows is wonderful rat poison. Warfarin thins the blood, works on the liver vitamin K pathway. And most people who need it know it's kind of a pain in the butt to take. You have to get your blood monitored, you have to watch your diet. But the new agents now are much better. So there's a new class of oral agents that are equivalent to warfarin that might make it easier to take these blood thinners if you need it. But you really need to work with your cardiologist and primary care doctor to see if this is something that might be good for you. The other ones that are harder are things like infection, inflammation, genetic disorders. We don't yet have treatments for all of these things, but we know certain infections can actually cause the heart to become ill, the blood vessels to become inflamed. These are ones that we treat with anti-inflammatories and strong antibiotics. These are much rarer causes and often affect our younger people. But it's something to think about. If you have a blood infection, we need to treat that quickly because that can cause heart damage and cause strokes because of the infection. So some of these can be quite serious. All right, I'm going to shift gears a little bit to talk about a case and kind of lead into some of our treatments. This was a 67-year-old woman I took care of. She presented with sudden onset of right-sided weakness. So if you use our FAST algorithm, her face was drooping. When you asked her to raise her arms, her right arm would drop. She couldn't speak. That's what aphasia is. She came to the ER and as soon as her family found her, but the last time they saw her normal was earlier that evening, about 4 hours. So we're right there pushing our time window of what we can do. We first do a head CT scan. This is a picture of a head CT scan because we don't know from those symptoms. Is she having a bleeding stroke? Is she having a blood clot or ischemic stroke? And from this, we see no blood. So our presumption is a major blood vessel's blocked. This is someone having an ischemic stroke. And she's in a window of time where we might be able to treat her. We actually have the ability in the same CT scan to look at the blood vessel. And you can see here, without being a trained radiologist, we love symmetry in the brain, and that part of her brain is missing a blood vessel. So right where that arrow is, the left middle cerebral artery doesn't show any blood flow. So she's having ischemia to the most important part of her brain. The left hemisphere controls her language. So what are we going to do? We know from these fancier images as well that this is a whole territory of brain at risk. All of that blue is that starving brain that's tissue is dying by the second here. We know it's not dead yet because the green tells us we can save it still. The red tells us that that part's probably too far gone. So we use some of these imaging techniques to help us see which patients we can still do some important therapies on. Some of these treatments aren't completely safe, so we want to select for patients who are not going to harm, but also give the best chance to recover. So as bad as her stroke symptoms were, even at 4 hours, a lot of her brain was still salvageable, still recoverable, because it's mostly green. And so we can see that on the first day, this is her scan here that she came into the ER with, and we treated her with a combination of IV TPA, which is our strong kind of Drano, thrombolysis. It dissolves blood clots quickly. She was treated under 4.5 hours, which is our maximum threshold, and we were able to help dissolve that blood clot. You'll hear more about some of our fancier techniques from Dr. Higashida, but you can see what she was left with was a much smaller little stroke here, and she saved a bunch of her brain that was on its way to having permanent damage. So this is a good case scenario of where we can treat someone quickly and help them recover. So these are the things that we think about. All the things that we can't do, but the things we can do, we focus on what we call revascularization, restoring that blood flow to the tissue that's at risk. And so in 2015, we have IV TPA, which you can give intravenously within 4.5 hours of the onset of symptoms. You can, if we're beyond that, we might have to go into the head using some fancier techniques that you'll hear about next. And these are new trials now that show that these new devices can maybe pull the clot out of the brain and restore blood flow. TPA, as you know, has been around since 1996, FDA approved. This is sort of the timeline of this drug. It's approved for 3 hours, and new trials that show it's efficacious up to 4.5 hours. So you don't want to push the window too long, but you want to try to get to the emergency room within that time window. And at UCSF, when you call 911, so that's the reason why you call 911. It activates the system even before you get there. You have to resist the urge of getting in the car and driving your loved one. It's much faster. And if the ambulance knows it's an acute stroke, they'll go lights and sirens, get you to the closest place as fast as possible. And so right away, they do the CT scan to make sure it's not bleeding. And then if you are eligible, you would get IV TPA as soon as we can give it. And our goal is door to needle time less than 60 minutes. So from the time you hit the door, you should be getting treated within an hour. And so we want to do this emergently. And so in the modern era, we have the IV TPA, And if the vessel's still closed, because it doesn't always work for everyone, we have some modern therapies that could really help. And you'll hear more in the next talk about that. And so we can treat stroke sometimes in cases out to 12 hours. So even though we might not be in the perfect time window, some of these new therapies open up the window a little bit longer on the right case-by-case scenario. But we know time is brain. So we want to still err on the earlier time point. So even though we have 3 hours, we don't just sit around and wait because the brain is at risk that whole time. And so we know the best data is for 60 minutes, which is why we pick that. If you do treat people out to 3 hours, guess what? That not all that brain comes back. And so we want to really prioritize sooner the better. Well, how does that happen? You know, if you live in San Francisco, you're lucky. You're only 7 square miles. You can get to a hospital very quickly. If you live in rural Nevada, you're kind of out of luck. There's not that many places. And so this is where our gaps in the country exist. We're lucky we live in a very urban area, but you can imagine stroke delivery of care is very hard in certain parts of the country. So stroke centers were an approach to try to equalize this a little bit. Let's say you are in a community hospital in the middle of California, and it's hard to get to any place. So you go to your local ED, and we often will try to coordinate care with them, use our stroke centers as a way to provide backup. They may not have a neurologist 24/7, and so we want to have an access point for that. So stroke centers are designed to make sure the expertise sits under one roof. We get inspected by the Joint Commission, state and federal regulators, so we know that our stroke care is up to par. We actually have a system of care that involves the ED doctors, the radiologists, the neurologists, everyone, the nurses, so that we can be as efficient as possible. And so these are some of the things that really help with that. And so there's 2 kinds of stroke centers. There's the primary stroke center, where they mainly give the IV, TPA, and medical support. And then this comprehensive stroke center, which Dr. Higashida will elaborate on. It really allows these fancier embolectomy devices and fancier tools to help people who maybe get TPA at an outside hospital and can come to us for care afterwards. And so this is that idea of like a spoke and hub. You might have not as many of these comprehensive centers, but you might have a lot of these community docs who can feed into us and help get care to these patients as fast as possible. And so these are the new challenges we face. We have these treatments, they're great, they work, but how do we deliver it to all? Because, you know, not all of us have the luxury of living within a few miles of a hospital. And so some of the innovative things, just to think forward, we're looking at mobile stroke units. So in Texas, where there's a lot of spaces and big state, and in Cleveland, they've been experimenting with these mobile stroke units. They basically put the CT scanner in the rig. So they have these special ambulances with a CT built in it. So now the paramedics can pick up a patient at their home, scan them right there, determine right away if they're having a stroke, and give TPA right in the ambulance, and then wheel them to the closest medical center. And this is something that might decrease that transport time, decrease that time to delivery of care. It's incredibly expensive to do it this way, because right now, a neurologist sits on that rig. And so they're doing a cost-effective analysis to see, is it saving enough lives? Is it worth doing this? And maybe it works in some places where they really don't have access to care. They do this in Germany, so it turns out that in Germany, that's part of your medical training. You have to ride the ambulance. And so when you take call in Germany, there's a doctor on the ambulance. So they do this in Germany, and they look at us like, what's the problem? But I think they're obviously a different healthcare system. They drive like madmen on the Autobahn. Their times to get to hospitals are really fast. So I think we can learn a lot from our European colleagues on how to deliver care. But these are some of the challenges that we face moving forward of delivering good care to people. But I'll leave you with some of the educational tools. I mentioned the American Heart Association and the Stroke Association. And we'll end with FAST. So if you take one lesson from today, share this with 2 of your loved ones. Share this with people you know. If your face is drooping, if your arm is weak, if you can't speak, you may be having a stroke and time is of the essence. Call 911. So this is, if that's the only thing you learned today, I've done my job. Okay. All right, I'm going to hand this over to Dr. Higashida now. I'm very privileged to work with him. Dr. Higashida is my partner in crime when it comes to these kinds of cases. We work very closely together to identify patients so that he can do his expert job in radiology. So he's a professor of radiology, also has professorships in every other department affiliated with this hospital. He is a true expert and has done a lot of the seminal work in developing these techniques and devices to deliver stroke care, including some of the earliest trials in intraarterial lysis and the new devices that you'll hear about today. And so I'm really excited to have him talk to you about the future of stroke care.
Well, thank you very much, Narissa. It's a pleasure to come and speak with you. Just as a background, I've been in the area of treating stroke for the past 30 years here at UC San Francisco. Our group actually is one of the largest groups in the United States. We have 6 full-time doctors that basically specialize in imaging and treating vascular problems of the brain and the spine. We cover the 4 hospitals. Our main hospital is here at Parnassus, but we also cover complex cases at the VA hospital, San Francisco General, and Mission Bay. And basically, we do about 12 to 1,500 procedures a year in diagnosing and treating vascular problems of the brain. So I'm going to discuss the radiological approaches to our current treatment of stroke. And as Dr. Ko has said, currently in the United States, there's about 800,000 new patients that present with a stroke each year. And of these, 600,000 are first-time strokes, and 200,000 are recurrent strokes. So if you or your loved one has a minor stroke or a first-time stroke, there's a very high incidence of recurrent stroke or secondary stroke. Stroke results in 130,000 new deaths per year. 1 in 20 deaths in the United States are due to stroke. And that averages out to about 1 death every 4 minutes as a result of stroke in the US. The annual healthcare cost for treating stroke is currently $34 billion per year annually, and it's the #1 cause of serious long-term disability. So stroke is now the 5th leading cause of death in the United States, and it can occur at any age. Generally, we think that strokes only occur in older patients greater than 55, 60, 65, but actually strokes can occur as a teenager or even in very young adults. 34% of stroke patients actually are less than 65 years of age. And the risk factors, as Dr. Ko has discussed, include high blood pressure, high cholesterol, smoking, and we now know that patients who arrive to the emergency room within 3 to 6 hours of stroke symptoms will have less disability if treated appropriately. So recognizing a stroke and calling 911 and getting to the closest emergency room will reduce the incidence of death or serious disability if treated appropriately. In terms of the overall global trends for stroke worldwide, we know that it's actually a growing global epidemic. 1 in 6 people worldwide will have a stroke during their lifetime. This results in 15 million new strokes each year, 6 million deaths per year due to stroke, 30 million stroke survivors with disabilities, and a disproportionate burden in developing countries, such as China, South America, and in countries like that. So according to the National Stroke Association, what happens if you have a stroke or your loved one has a stroke and they don't die from a stroke? Well, 31% of patients will require long-term assistance with care after a stroke. 20% will need help walking. 16% have to be institutionalized after a stroke long-term. And 71% are vocationally impaired even after 7 years following a stroke. So it does result in long-term disability. And again, 35% of all patients are younger than 65 years of age that have a stroke. Again, we know that stroke awareness is very important. only 1% of the population could name stroke as a leading cause of death. 40% of the population did not know any warning signs of stroke. 12% did not know what any of the risk factors were for stroke. And 50% of the population didn't even know when a stroke might occur. Therefore, public education about stroke is very important, and that's why the American Heart and the American Stroke Association is now trying to give a lot of public information about the symptoms of stroke and what to do when a stroke occurs.
You have 60 minutes to win or lose the race of your life. With every second, a stroke can kill a part of your brain that may control movement, sight, or speech. Now there are new treatments, but you must get to a hospital fast. If you suddenly feel numbness on one side, have trouble talking, walking, or seeing, it could be a stroke. Call 911. If you have a stroke, how you spend the next 60 minutes could determine how you spend the rest of your life.
So again, much like heart attacks, stroke, once it's diagnosed, can now be treated effectively, but you need to get to the hospital as soon as possible. So what happens if you're developing a stroke or you think you have a stroke and you go to the emergency room? Well, the first thing that they do is hopefully they have a stroke neurologist that could come down and evaluate you quickly and determine if they think you're having a stroke. The next major test is a CT brain scan to determine if you're having a stroke and what the cause of the stroke is. So normally within the first 3 to 4 minutes of evaluating you and determining if you might be having a stroke, they'll rush you to get a CT brain scan. And what this tells us is if your stroke may be due to a blood clot causing insufficient blood flow to the brain, or if it's due to bleeding in the brain. And that's why we get the CT brain scan. We then start an IV and we give contrast through your veins, and the contrast goes into the brain, and we look at the blood vessels for a cause of the stroke. And basically what we're able to tell with the CT brain scan with contrast is if there's a cutoff of a major blood vessel in the brain such as this. And this cutoff indicates that there's a blood clot causing injury or damage to the brain tissue. And we can reconstruct this in a three-dimensional view. And again, you can see more clearly here that this blood vessel does not fill out in this area compared to the normal side. And that's what we look for with a CT brain scan. We're also able to look at the relative blood flow to the entire brain tissue. And this is called a CT perfusion brain map. And what this does is we can color code and look at the blood flow, comparing lack of blood flow in the blue versus normal blood flow in the yellow and green. And this indicates the relative area of damage that you're at risk for due to lack of blood flow from a blood clot in the brain. These are the types of images we're now routinely able to get with a CT brain scan. And basically, we're able to image the entire area from the chest all the way up through the neck blood vessels. And you could see the excellent detail of the blood vessels, both as the blood flow is going up through the neck, through the carotid arteries, and as it is entering the brain. And we could actually look at the specific blood vessels down to 2 to 3 millimeters and try to identify where the blood clot is in your brain and if it's amenable to treatment. And we now have actually second and third generation CT scanners that give us even more detail. So these newer CT scans now can perform 7,000 slices within 60 seconds. And we're able to reconstruct these images within 5 minutes. So what happens when you get into the brain scanner is we start an IV, we give contrast. The contrast tracks up from the heart, up through the blood vessels in the neck and into the brain. And we're obtaining 7,000 slices within 60 seconds to basically image the entire blood vessel in the brain as shown here. And these are the types of images we're able to obtain looking at the blood flow in the brain. And so this is the arteries as it's going up. It breaks into smaller and smaller vessels called capillaries, and then it reconstitutes into veins. And it gives us basically an excellent map of all of the blood vessels in your brain, and it can identify where the source of your blood clot is to see if it's amenable to treatment. So this is what the normal brain blood flow looks like in your brain. These are the carotid arteries, and this goes to both the right and the left side of the brain. And then the back of the blood vessel is the vertebral-basilar artery, which supplies blood flow to the cerebellum and brainstem. And as Dr. Ko has said, depending upon where the blood clot is, determines what symptoms you might have as a result of a stroke. And again, we can also do what's called perfusion mapping to look at how much blood flow is actually going to your entire cortex. And again, this is color-coded, and the area in blue is area that lacks normal blood flow versus areas of green, which is normal blood flow tissue perfusion. At UC San Francisco, we were actually one of the first hospitals in the world that developed this hybrid unit, which contains both an MRI brain scanner and an angiography suite. So this technique allows us to evaluate patients very quickly with two different types of imaging modalities. When a patient comes in with an acute stroke, we could bring them into the MRI brain scanner and do a non-invasive scan of the brain to look at the brain tissue and to screen patients for a cause of stroke. If we find a major blood vessel that's blocked, we could then slide the patient over into the angiography suite, and we could do X-ray imaging to try to treat you as quickly as possible and retrieve the blood clot out of your brain. So again, this is our hybrid interventional MRI unit that was actually developed here at UC San Francisco about 10 years ago. And we're able to place a patient into or onto this table, slide the patient into the MRI brain scan, look at the brain tissue, and if we can identify a treatable cause of a stroke, slide the patient into the angiography suite and treat you immediately. And these again are typical images we're now able to obtain with our MRI brain scanner. This is a little different than a CT brain scan in that it gives us different information. But basically, an MR scan looks at the normal cortical tissue of the brain. So this is what your brain normally looks like. This is the back of the brain, the occipital lobe. Your brain stem is located down here, and the front of the brain is the frontal lobe and temporal lobes, like this. And then these are the draining veins and dural sinuses that drain blood flow from within the brain back to the heart. So this is a three-dimensional topographical brain imaging that we're able to obtain routinely so that we can non-invasively look at your entire brain, all within 5 minutes. So not only can we look at the topography or the outside of the brain, but of course we could actually slice through it in different planes and look at the inside of your brain to see if it's normal or abnormal. So these are axial brain scans in which we actually can slice through 1 to 2 millimeters of the brain and look or section, basically through the brain tissue itself. It's like cutting through your brain non-invasively. And this is a patient that actually presented with a stroke due to a blood clot or hemorrhage. And what we're able to see is this white substance here in the brain here, and this is a blood clot, which caused a stroke in this patient. And we could also do multiplanar reconstruction, in which we're able to basically slice through the brain in 3 different dimensions, as shown here. And again, this is what we do routinely every day. We probably do between 80 to 100 scans like this on patients every day, looking for different causes of patients that might be having a stroke or are at risk for stroke, or we're looking if you have symptoms of headaches or dizziness. we're able to see and visualize your entire brain structures to see if it's normal or abnormal. So one of the major causes for stroke is due to atrial fibrillation, in which the heart is beating irregularly. And if your heart is pumping irregularly, what occurs is you can form blood clots in the atrium of your heart, and if a blood clot forms, it breaks off, and the first 3 blood vessels that come off the heart all go to supply blood flow to the brain. So this is a blood clot that is broken off from the heart and travels up into the carotid blood vessels, and it lodges in one of the blood vessels in your head. And this causes 20 to 30% of all strokes in the United States is atrial fibrillation, if not treated properly. So what occurs is after a blood clot breaks off from the heart, it travels up in the carotid artery, and if the clot is large enough, it can actually lodge in one of the main blood vessels supplying the hemisphere. This is in the middle cerebral artery. So what occurs is a blood clot forms, breaks off, and because it now stops blood flow from traveling to the brain, this is what causes cerebral ischemia or stroke, is lack of oxygenation to this part of the brain. So this is what your brain would look like if you have a blood clot to the middle cerebral artery. This is dead brain tissue, which then swells up and can cause death in 30% of cases. So if you have a blood clot that lodges in your main middle cerebral artery, it carries a 30 to 35% immediate mortality rate or death rate. 40 to 65% will have severe long-term disability, and only 12 to 15% of patients that have a blood clot in the middle cerebral artery will have minor non-disabling deficits, but they'll still be disabled. So what we see with a CT brain scan is if you have a large blood clot in the middle cerebral artery, it causes massive swelling, secondary hemorrhage can occur, and because of this massive swelling, it causes herniation and death in 1/3 of cases. So the first successful trial for treating patients with stroke was the National Institutes of Health TPA stroke trial that was published in 1995. And basically what this study was a randomized study in which patients that came in with a large vessel stroke, or actually any stroke, were given intravenous TPA. TPA is tissue plasminogen activator, which dissolves blood clots throughout the body. And what they found was that if you were treated within 3 hours of stroke symptoms, in 624 patients that participated in this trial, 30% of those patients that were treated had a 90-day improvement in function, with a 5.8% increase in bleeding overall. But based upon this study, intravenous TPA became the standard of care in 1996 for the treatment of stroke. But since only 30% of patients improved after intravenous TPA, that still meant that 70% of patients with a stroke didn't get much better. And so for that reason, we as interventionalists began to look at new treatments for patients with large vessel strokes. And these were all the trials that we participated in and actually helped to develop throughout the years. In the late 1999, I was actually the national principal investigator for intra-arterial thrombolytic therapy in stroke. And in 2005, Dr. Wade Smith and Dr. Koh were actually the national leaders in the Mercy corkscrew device, which was approved in 2005 to treat stroke. And then in 2009 and 2012, there were 2 additional stroke treatments that were approved. And all of these medical techniques and devices were actually pioneered at all of the major stroke centers throughout the United States with an endovascular approach. So if you are having a stroke and you're not responding to intravenous TPA within 6 hours, what occurs is if you go to a tertiary care hospital or comprehensive stroke center like UCSF or Stanford or CPMC, which are the three major stroke hospitals, and there's also what, San Jose? Yeah. There's probably 4 hospitals in North Bay where you should go if you're having a big time stroke. So it's here, Stanford, San Jose Regional Medical Center, and CPMC all have capabilities to do interventional treatment. And basically what we do is we bring you to our angiography suite. We put a tube called a catheter into the blood vessel in your leg, and under X-ray guidance, we guide it up through the abdomen, through the chest. We take this catheter or tube up into the blood vessels in your head and neck and directly into the brain, as shown here. And this is what our angiography suite looks like. And again, on average, we do about 4 to 6 procedures like this per day to both diagnose and treat patients with different types of strokes. And this is what our angiography suite looks like. So basically, we're working from the blood vessel here in the leg, but with X-ray guidance, we can track the catheters in the neck and into the brain, and we're able to visualize what your blood vessels look like on these X-ray screens. And what we could do is we take these catheters up through the blood vessels in your brain, and we direct it to the site of the clot. And initially, we had drugs that were able to lyse the blood clot, and we could infuse these thrombolytic drugs to dissolve the blood clot, and if we did it quick enough and opened the blood flow back up, you could see that we could restore normal blood flow to the brain and reverse the effects of a stroke. So that was the first generation techniques. We're using drugs to dissolve blood clots. But there was an increased incidence of bleeding with those types of lytic drugs. So the next devices that were developed were these mechanical thrombectomy devices. And the first generation device was this corkscrew device in which we were able to take a tube or catheter to the blood clot in the brain and deploy this thrombectomy device to pull the clot out. And this was actually our very first case that I did about 10 or 12 years ago. This was a 31-year-old male that had injured his neck playing football, actually, on Thanksgiving Day. And he basically lost consciousness and stopped breathing and was brought to the emergency room. And this is an angiogram in which we inject dye or contrast into the blood vessel in the brain. And this is the back of the brain called the basilar artery. And what we see here is a filling defect at the top of the basilar artery. And this is because there's a blood clot that has traveled up and lodged in his basilar artery, and so there's no blood flow going to the top of his brain stem. And because there's no blood flow to the back of his brain stem, he's basically comatose. And we know that if nothing is done, he's got about a 90% chance of dying from this because he can't breathe and can't move. So this is, again, another view showing the blood clot here. This is a filling defect. And because we know that if we don't do anything, he's going to die, we went up with our thrombectomy device and catheter up from the leg through the abdomen and chest into the neck and into the brain. And we deployed this corkscrew device called the Mercy device into the clot here. And we gently pulled back, as shown here, and we pulled out 7 centimeters of blood clot in his brain, as shown here. So this is a big blood clot that lodged in the brain that we pulled out. And this is now, after pulling that blood clot out, you can see that we've restored all the blood flow to the top of his basilar artery, and now we have restored normal blood flow. And so basically, after we pulled the blood clot out, 2 hours later, he woke up, and he actually walked out of the hospital 2 days later, and he's completely normal. So, this was a great save, and it showed us that these techniques can work. So we've gone through several different iterations, and our devices that we now use are these stent retrievers. And this is what these new devices that we're now utilizing to treat patients with stroke. So this is the technique that we currently use if you're having a stroke in your brain. This is a thrombectomy device, and again, we do this under X-ray guidance in the angiography suite, and this is what it looks like when it's deployed. Basically, what occurs is if you have a blood clot, again, in the brain, usually in the middle cerebral artery, we take this microcatheter up under X-ray guidance, track it up through the blood vessels in the head, neck, and brain. This is your blood clot in the middle cerebral artery. And under X-ray guidance, we track this small tube called a catheter up through the blood clot, and we use a guide wire to poke through the clot. We then pass this tube just distal to the blood clot. Once the tube is past the blood clot in your brain, we then pull the guide wire out. We place this thrombectomy device across the blood clot, back the catheter out, and then this stent retriever opens up within about 15 to 20 seconds. The stent retriever then captures the blood clot, as shown here. Once the retriever is up, we then gently pull back on the stent retriever that holds the blood clot. And we pull this out of your brain through the blood vessels in the head and neck and into our guide catheter, which is located in the neck. So here is the blood clot being pulled back gently. And once we have the blood clot firmly captured, we then pull it all the way back into the neck and into the guide catheter shown here, and then we suck it all out once it's to this point. And using these latest techniques, we now have an 80 to 90% rate of reperfusion in which we're able to capture large blood clots. So there have now been 5 major trials worldwide showing that patients that have major strokes due to blood clots in the brain will respond better and improve with this new technology if they get to a comprehensive stroke center. So these are the different trials that were recently published this year, all showing benefits for interventional neuroradiology and thrombectomy devices. So in conclusion, endovascular therapy is highly beneficial as compared to intravenous TPA alone up to 6 hours of stroke onset. There's an absolute benefit in good functional outcome at 90 days, which ranged from 13% to 31% based upon these 5 clinical trials that were published this past year. So that means that the number needed to treat to benefit is only 3 to 7 patients. There is no significant increase in the rate of symptomatic bleeding related to this treatment compared to patients that weren't treated. And due to the significantly higher and faster complete recanalization rates with stent retrievers versus intravenous TPA alone, all eligible patients that aren't getting better with intravenous TPA should be treated by these techniques. So if you're having a stroke, or you think you're having a stroke, you need to call 911 immediately and go to the nearest stroke hospital. If your stroke is less than 4.5 hours, you may be a candidate for intravenous TPA to help dissolve the clot. If you're given IV TPA and you're not improving, you may be a candidate for interventional therapy to snare the clot out, but only if you go to a comprehensive stroke center. So it depends where you go. And this treatment, if successful, can significantly improve your overall neurological outcome at 90 days. So thank you very much. So we're able to take some questions. Yes?
So the question is, what's the optimum blood pressure? 120/80 is the number that we showed on the slide, and that calculates to a mean arterial pressure of only 67. Is that enough? On average, if the brain is otherwise normal, We don't need a mean arterial pressure more than 50 or 60. We actually survive on that. But you're right, each individual person is different. So there may be a case where we choose a higher target blood pressure because that's what that individual brain needs. In general, if you can tolerate a lower blood pressure without symptoms, overall it's a better burden on your system. So if we're really talking about sort of decreasing the kind of impact of high blood pressure across the board on all those blood vessels, the lower the better. But you're right, there is no absolute low number for each individual person. So these are numbers that are targets, but maybe each person individually needs to kind of figure that out for themselves. In general, our blood pressures are overall too high. When we poll patients who have high blood pressure, they're never optimally treated, because when you come to your doctor's office, it's a little high. And we sort of say, well, that's the white coat hypertension, let's just watch it a little longer. Well, months and months and months go by and the blood pressure consistently stays high. So I don't think we do a very good job of treating blood pressure. But you're right, in an individual case, sometimes the blood pressure is a little bit higher than that. But on average, if you have a healthy circulation, that blood pressure is more than optimum.
But a 70-year-old usually doesn't have a normal vacuum.
Exactly. So yeah, so I think we do have to optimize that. And so it doesn't mean going from 200 down to 120. We would all pass out with that. So we don't want to overtreat, but we want to gradually get the brain used to a healthier blood pressure over time, because it's better for your heart. Your heart doesn't work so hard to do that, and your vessels don't stiffen. So what we call hardening of the arteries, that's one of the challenges. If your arteries are so used to high blood pressure, they're stiff and hard. And I think one of the things we want to try to retrain the blood vessels to do is become more compliant, more supple, and actually having a lower blood pressure generally goes with having kind of healthier blood vessels in general, not so rigid. But yeah, for folks who have suffered for high blood pressure for many years, it takes time. And we know on the opposite end, if we overtreat people's blood pressures, that doesn't help them either. We don't want people passing out and having issues with that. So I think we have to have an individualized plan for each person. In general, if someone has newly diagnosed high blood pressure, we really want to target a pretty aggressive goal as low as someone can tolerate. The lower the better. But that may be different for every individual in this room. There's a question here?
Yeah, but what you're saying, what percentage would you say of 75-year-olds have a 120 over? I mean, very, very few, right? Maybe
Yeah.
1%?
No, it's high. So that's the difference. I think it's a misnomer to think that healthy older people can't have a normal blood pressure.
You really? How many of them do you have any idea that you could cite? I'm sure it's less than 1%.
Yeah, and I think it depends if you have high blood pressure as a disease. There are a lot of people who actually, believe it or not, don't actually have high blood pressure. They have a normal blood pressure no matter their age, because they don't have high blood pressure as a disease. So it really depends. You know, I think when someone has the disease of high blood pressure, it is a hard disease to fix. It's very challenging. And for many, we're just trying to get them out of the dangerous 200 milliliters of mercury zone, trying to lower them to some safe zone in between. But I don't think you should just accept that if you're old, you should have a higher blood pressure. That's not true.
No, but you're not answering my question.
Mm-hmm.
I ask you, what percentage do you think of people that are 75 to 80 have 120?
If they're optimally treated and managed well, we don't. I would say you're right. The majority of older patients are not optimally managed. I would say their blood pressure is too high.
What percentage?
Yeah, I'm a neurologist, so you have to kind of get a different perspective. I'm a neurologist, so I treat people with strokes. So for me, those patients need a significantly lower blood pressure than someone who's walking around who doesn't have that. So my patient population is skewed towards those who have really bad blood pressure. And we try really hard to lower their blood pressures to less than 140/90 as a first goal, and then try to really gradually get them to a healthier blood pressure below that. Sometimes it takes 4 or 5 drugs, and they actually do better, and their brains are healthier for many, many years later. This is the silent killer in America. High blood pressure is an epidemic in this country. And so I agree with you. The answer to your question is most patients have too high a blood pressure. Absolutely. I totally agree with that statement. Yes?
Yeah, can you address both the diagnosis and treatment of hemorrhagic strokes? Probably another lecture, but.
Yeah, no, it's a big problem. So the flip side, it actually ties in well. So hemorrhagic stroke. What's the biggest risk factor for hemorrhagic stroke? It's high blood pressure. What causes those fragile blood vessels to break? It's too high a blood pressure. And once your blood vessel bleeds, there's not a medical therapy out there. That's the problem. So once you have we talked about all these innovations, we've made the prime time, we're on ER for stroke intervention therapy. That's for the ischemic stroke. Guess what? If you have a hemorrhagic stroke, it is more fatal, more disabling than an ischemic stroke. More people die from a hemorrhagic stroke because once the blood leaks out and your brain swells, there's not a whole lot we can do. And the only thing we do, as soon as that person comes into the ER, we drop their blood pressure to 140. Because the reason they have that most commonly is because their blood pressure's too high. And so that's one of the challenges, is how low is too low. I agree, there's a lot of controversy over that. I think we want to try to optimize blood pressure for each individual person, but in general, it's actually on the lower side. It's not on the higher side of things. Yes?
Do you save those advanced techniques you were showing us at the end there? Do you save those for certain optimal candidates?
I'll let Dr. Higashida answer.
Right, the question is, when do we do these more comprehensive, more highly invasive procedures? First of all, the patient has to get to the hospital within 6 hours. We have to begin to initiate this treatment before that 6-hour time window, because after 6 hours, there's irreversible brain damage. So this is a medical emergency. The indications are, if you don't respond to intravenous TPA, you're diagnosed with a blood clot in a major artery, and you have a moderate to significant stroke. Those would be the main indications. But there are also some exclusion criteria that you may want to address.
So the limitation of some of these is that you have to be able to reach these blood vessels. So if the blood clot is too far distal or too deep, we may not be able to reach them with the devices in their current iteration. If there's already too much damage and the tissue is already ischemic and dead, by opening up the blood vessel, sometimes we actually cause injury and harm. So we actually restore blood flow to tissue that's already gone. And so we actually can make things worse. And that's one of the critical decisions is, yes, there's a time window, but each person's brain is different. Some people at 12 hours have a lot of tissue that we can salvage because other blood vessels have been helping. And someone who comes in at 60 minutes, sometimes it's too late already because the brain tissue is already dead. And so we try to individualize a safety profile for each one of these folks. But right now, our main issue is most people don't come to the ER within 3 hours. Most people are coming in on average 6 to 12 hours later. So it doesn't give us the opportunity to treat people. So that's still the barrier to care. Yeah.
Doctor, we recently had an emergency medicine course in this program. And Dr. Brown, we discussed the possible advisability of a patient or an at-risk patient carrying on their person a USB device with their relevant history, because you can't communicate if you drop dead if you drop down in Market Street somewhere. But anything that would expedite the information to the ER, to the EMTs before they get to you. I mean, we saw this wonderful equipment you have, but in the time before a person comes near, would something like that be useful?
Absolutely. Yeah, no, I think the question is, is there something that individual persons can carry on them to help expedite emergency care? I tell all my patients, all EMTs are trained to look for your wallet and ID. And so oftentimes on the back of where your ID is, whether it's your driver's license or some kind of ID, just that size, a little business card size, you can just put it right there, a card with your emergency contact person, which person you would trust to call in case you are incapacitated, a list of your medications, because it really matters if you're taking a blood thinner, if you're on a high-risk medicine that our treatments might put you at higher risk for, and a list of, maybe just a short list of your medical problems. If you have atrial fibrillation, if you have heart problem, that might actually increase our suspicion you might be having a stroke event because you have these risk factors there. So even just a short list of medical problems, not even all the doses, but just medications and emergency contact, that will go a long way to do that. We are getting closer and closer to having electronic medical records that talk to each other. So if we can look you up and we know you are someone who maybe gets their care at Kaiser, we can actually look at your medical records from Kaiser now, from UCSF, and vice versa. So there are ways now we can get information. I think the modern technology might be microchips and things like that. Many of my patients who really have serious medical ailments wear a medical alert. Most of the things you're talking about, maybe that's too much, but I think even just a little business card right behind your ID, the paramedics will find that immediately. That's what they're trained to do. Yes?
Do you have a stroke center here at Parnassus as well as Mission Bay?
Yes. We have strokes that are treated both at Parnassus and Mission Bay. Mission Bay is primarily a pediatric and obstetrical place, so they typically have a lower risk population because they're generally healthier and don't have stroke risk factors. But certainly when those young folks do have strokes, we have the capability of treating them there. Yes?
We hear a lot about symptoms of stroke, you know, the drooping, physical, the verbal, and so forth. But it was only recently that I learned that there can be emotional symptoms as well. And those don't always manifest right away, but once somebody recovers enough, they are altered in terms of their personality, their character, and sometimes these emotional disturbances can really be sort of dangerous. Can you explain that a little bit?
Yeah, so the question is, what are some of the other effects of stroke that we didn't talk about today, mostly related to emotional status, even cognition? So we talked about sort of the obvious emergency things that are there that are often a physical manifestation of a stroke. It's even harder to tease apart the cognitive aspects, the emotional aspects, as you know, our brains are sophisticated organs. It makes us who we are. And that's why it's most important to treat this as an emergency, because damage to certain parts of the brain can change your personality forever. It can take away the essence of who you are. Many people, if you poll them, they might be okay with losing a little bit of dysfunction in a limb. They would not be okay if they lost who they were as a person. And I think those are highly valuable. And that, you know, we use these warning signs as a way to enter into the medical system, but more importantly, to save the function of the brain that's what we call higher order function. Emotional state, how we deal with emotions, how we think about things, how our memory and it functions. Those things are even maybe more valuable in terms of our recovery. And so some strokes, because emotions do live in a part of the brain, if you damage those parts of the brain, people sometimes lose control of their emotions. We call that kind of emotional incontinence or lability of emotion, where they're actually not depressed or sad, but they are prone to crying. And on the opposite token, they laugh kind of inappropriately, and that's actually a stroke symptom. And often in a late phase. We don't often diagnose that in the beginning of the stroke. It's often in recovery that we're able to tease apart these more sophisticated stroke symptoms in someone who's recovering from a stroke. And those things do get better, but often more challenging to recuperate from. So I think, you know, those things matter maybe more so than some of our physical ailments, and even more reason to really focus on prevention. Yeah. Oh, did I miss a? Go ahead.
To what extent are contrast dyes very central to the type of diagnostic work you do? My mother my mother was allergic to contrast dyes, and I'm not sure if there's any way that people can sort of check that out beforehand.
Contrast.
Did she know she had a contrast allergy beforehand?
No, no.
And what kind of contrast allergy did she have?
She had a series of mini strokes brought on by the dye.
Really?
Yeah.
That's very unusual.
Yeah.
Well, normally, you know, contrast, you can have allergic reactions to anything. And there is a small percentage of patients that may have an allergic reaction to the contrast itself, and there's different levels. So the mildest symptoms are basically just itching and hives that develop. But a very small percentage can have what's called an anaphylactic reaction, where you can actually stop breathing or you develop problems with respiration. So there's different gradations. If you just have mild allergic reactions, we can pre-medicate you, usually with some drugs beforehand to stop those mild reactions. But obviously, if you know somebody does have a history of significant allergies to the contrast agent itself, then we probably would not give it to you if it's a major contrast reaction. But it's very, very unusual to have a contrast actually precipitate a stroke. I mean, that's very, very rare.
But you do use contrast dyes in almost everything you do.
Well, actually, if you present with a stroke, the first thing we do is get a non-contrast CT brain scan to basically determine if it's a hemorrhagic versus non-hemorrhagic stroke. We only give contrast if we think it's going to let us know if a blood vessel is involved and if it's a large vessel versus small vessel stroke. So
Time for one more question? Yeah.
Any last questions? Yes.
Yeah, so we live in the Bay Area. Where do we tell the ER to take us? It's too far to come here. Is Stanford?
So there's the question is where do you go if you're having an acute stroke in the Bay Area? So I think because of these new therapies, everyone has to up their game. We have a challenge of delivering care to everyone, and we all have to meet that challenge. We owe it to you guys. And so every hospital in the area is ramping up to spread this kind of treatment. So currently in San Francisco, CPMC and UCSF are capable of interventional therapy. There are lots of hospitals who are stroke centers that can give TPA.
I'm talking south.
So in the South Bay, there's actually the Good Samaritan Hospital is a stroke center. They actually have an interventionalist there. Stanford is also a comprehensive stroke center. So those would be the main options. But there are a lot of local hospitals who have now primary stroke center capability. So what they could do is initiate the workup, start the TPA if it's appropriate, and then immediately transfer to like a Good Sam or Stanford. So that's this idea of spokes and hubs, because we can't have luckily, we don't need an interventionalist in every single hospital in California, but we need access. And so we use a partnership where we can use telemedicine, coverage to help facilitate those transfers quicker. So the best thing is just go to the closest stroke center. And then if you are someone who might benefit from interventional comprehensive stroke center, we have networks in place to cover a broader area. We want no part of California uncovered. That's the goal. We're not there yet. But in the Bay Area, we're lucky because we actually do have quite a few centers that can deliver this care now.
And just a comment to that gentleman, I'm 72 and my blood pressure is 125 over 70. I have high blood pressure, I'm on medication, and I used to be 190.
You're on medication?
Yes. Yes.
Yeah. It does take medicine, unfortunately. Thank you guys so much. I really appreciate it.